Hi, I'm Joe Graydon.
And I'm Terry Graydon. This podcast of the People's Pharmacy is brought to you by Squatty Potty Toilet Stools. They create healthy toilet posture for fast, easy elimination. Learn more about toilet posture and health at squattypotty.com. That's SQUATTYPOTTY.com.
We've all experienced digestive distress. It's usually temporary, but for millions, the pain and inflammation are unrelenting. This is the People's Pharmacy with Terry and Joe Graydon.
Dr. Balfour Sartor is a physician with expertise and experience with inflammatory bowel disease. He'll share his approach to diagnosing and treating Crohn's disease and ulcerative colitis.
Probiotics have gone mainstream. Millions now take pills or eat foods such as live culture yogurt, kefir, or sauerkraut. How well do probiotics and prebiotics work to control gastrointestinal symptoms?
Coming up on the People's Pharmacy, Dr. Balfour Sartor will answer your questions about inflammatory bowel disease and other digestive tract trouble.
First, this news.
In the People's Pharmacy Health Headlines, men with male pattern baldness may be at higher risk for aggressive prostate cancer. That's the finding from a study of nearly 40,000 men published in the Journal of Clinical Oncology. The researchers analyzed data from the U.S. prostate, lung, colorectal, and ovarian cancer screening trial. The volunteers, enrolled between ages 55 and 74, were asked to describe their hair loss at age 45. During follow-up, more than 1,100 men developed prostate cancer, with 571 men diagnosed with aggressive tumors. There was an association between aggressive prostate cancer and hair thinning, both on the forehead and the crown of the head. Men with that type of hair loss were 40% more likely to be diagnosed with aggressive prostate cancer during the follow-up period. One explanation is that both male pattern baldness and advanced prostate cancer are likely to be driven by testosterone and its metabolites. This was an epidemiological analysis and does not prove cause and effect. Nevertheless, men with this type of male pattern baldness may want to discuss their risk of prostate cancer with a healthcare provider.
Narcotic medications can be essential for managing severe pain, but they can also cause quite serious constipation that's difficult to control with everyday remedies or laxatives. Sometimes the constipation is so intractable that the person must abandon use of the pain medicine. The FDA has just approved a prescription pill that will be able to counteract the opioid effects of drugs like oxycodone on the large bowel without affecting pain relief elsewhere in the body. Naloxone will be sold under the brand name Movantik. An article published in the New England Journal of Medicine reported that the drug was helpful in overcoming narcotic-induced constipation. In 2 clinical trials, naloxone was helpful over 40% of the time, compared to placebo, which helped about 30%.
People with the autoimmune skin condition vitiligo have depigmented spots on their skin. This is especially noticeable in individuals with darker skin color. Until recently, there have been few, if any, effective treatments for vitiligo. Dermatologists at the Henry Ford Hospital in Detroit report in JAMA Dermatology that they've had success achieving repigmentation of skin affected by vitiligo. They administered a medication called afamelanotide, which encourages skin pigment, and then treated patients with narrowband ultraviolet B phototherapy. The volunteers received 2 to 3 phototherapy sessions a week for 6 months. In a comparison with phototherapy alone, combination therapy worked faster and was more effective. Nearly 50% of those treated with this dual approach had satisfactory repigmentation at 6 months.
Researchers call it abdominal adiposity. People refer to the expanding waistline as tubby tummy. Packing on pounds around the belly has become increasingly common. According to the CDC, the average American waistline has been growing for the past 14 years. The average waist circumference rose from 37.6 inches in 1999 to 38.8 inches in 2012. Men gained almost an inch, whereas women gained an inch and a half. The number of people categorized as having abdominal obesity went from 46% in 1999 to 54% in 2012. Waistlines greater than 40 inches for men and 35 inches for women qualify as abdominal adiposity. Belly fat is especially worrisome because it contributes to metabolic syndrome and the risk of diabetes and heart disease.
Statins such as atorvastatin, rosuvastatin, or simvastatin have been the mainstay for cholesterol control for decades. The evidence that they prevent second heart attacks in middle-aged men is indisputable. What's been much less clear, however, is whether such medications can protect older people. A new analysis published in the Journal of the American Medical Association points out there's no good evidence to support statin use after age 80. The randomized clinical trials that would provide the evidence in this age group have not been carried out. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon. I'm a medical anthropologist.
And I'm Joe Graydon. I'm a pharmacologist. Today, our topic is one that's often considered taboo for polite conversation. Bowels, how they work, and what happens when things go terribly wrong.
We'll be discussing the latest approaches to inflammatory bowel disease, that's Crohn's disease, and ulcerative colitis. There's been a lot of confusion about why people develop such serious conditions, but scientists are starting to unlock the secrets. If you have a question about inflammatory bowel disease, or IBD, we invite you to give us a call. The number is 888-472-3366. You can email us. It's radio@peoplespharmacy.com, or contact us on Twitter. It's at People's Pharmacy. The number again, 888-472-3366.
Here today to answer your questions is Dr. Balfour Sarter. He's the Midget Distinguished Professor of Medicine, Microbiology, and Immunology, and Director of the UNC Multidisciplinary Center for IBD Research and Treatment. He's co-director of the Center for Gastrointestinal Biology and Disease, and until recently, he was the chief medical advisor of the Crohn's and Colitis Foundation of America. Welcome to the People's Pharmacy, Dr. Sarter.
It's a great pleasure to be here.
Thank you.
Dr. Sarter, please start us off with some basic information. What is inflammatory bowel disease, and how does it differ from other conditions, especially irritable bowel syndrome, which a lot of people get confused because the initials are so similar?
Thanks. That's a great place to start. So inflammatory bowel diseases, I like the plural because it's a spectrum of Crohn's disease and ulcerative colitis, is a chronic inflammatory condition that involves the lower part of the GI tract, the colon and the end of the small intestine, most frequently in Crohn's disease, and the colon only in ulcerative colitis. The reason it can get confusing is that there are overlapping symptoms between irritable bowel syndrome, or IBS, and inflammatory bowel diseases, IBD. The symptom overlap is the abdominal pain, cramping, and altered bowel habits. IBD, or Crohn's and ulcerative colitis, is chronic inflammation associated with weight loss, bleeding, and on a colonoscopy, discrete ulcers that you can see with obvious inflammation, where IBS, or irritable bowel syndrome, is more of a motility problem. It is a hypersensitivity of the nerve endings where they're more sensitive to stretch, which is the major impetus for pain in the GI tract, usually without weight loss and without bleeding unless they're hemorrhoids associated.
Now that last condition, that irritable bowel syndrome,
Yes.
IBS, affects an enormous number of people. I mean, it's greater than, 30 million Americans, 1 out of 5?
Yes. So Doug Drossman did a very interesting study many years ago in entering freshmen at UNC and found that 20% of the entering freshman population had symptoms consistent with irritable bowel syndrome, which can be alternating constipation or diarrhea or either one alone.
Now, of course, for the person who's affected, it's a quality of life issue, and we're going to come back to it a little later in the show. But for those with inflammatory bowel disease, like ulcerative colitis, like Crohn's disease, it's much more than a quality of life. I mean, it can be life-threatening.
Oh, it can indeed. Fortunately, the mortality rate is quite low, but the ability of patients to continue a normal life is a real problem. It affects about 0.5% of the population as opposed to IBS, but that equates to about 1.4 million individuals in the United States.
Well, do we have any idea what's behind it? What causes it? Why do so many people suffer from this inflammation of the digestive tract?
Well, it's still a somewhat unknown area, but there's active investigation. So it seems to be an interaction between genetic, environmental, and immune-mediated processes. So as opposed to the older feeling that this is an autoimmune process, the current belief is that it's an exaggerated immune response to your gut bacteria, the bacteria that live in everyone. And there seems to be a genetic predisposition. 163 genes have been implicated in either Crohn's disease or ulcerative colitis, or in both, showing that these can occur in the same families.
Now this is new thinking.
Yes.
This is a radical departure from the old days of 3 decades ago when I was in graduate school, or 4 decades ago now, where we thought this was the body attacking itself, that the body was, for reasons that were somewhat mysterious, going after the colon and causing these terrible lesions. And sometimes people would literally have their colons removed, and I suspect that still happens today, but the thought was it's because the body can't really determine self from non-self. It's been triggered somehow to go after self. Now what you're saying is, it's quite different. It may be the immune system is reacting to bacteria in the colon.
Joe, that's exactly right. So the evidence is that there is an exaggerated immune response, but rather than your own cells being the target, it's your own bacteria. So you could argue that it may be self because people carry the same bacteria throughout most of their lives. But the difference in the thinking is that this gives a different target for treatment, in that if you could alter the gut bacteria as well as dampen the immune response, which is the primary way that we are currently treating patients with immune suppression, that maybe a new way of approaching this would be to alter the gut microbiota. That'd be a much more physiologic approach.
Now, when you say microbiota, you mean the bugs in our belly.
Absolutely. But it's not only the bacteria. They're the viruses and the fungi that really we know very little about. That's an area of very rapidly escalating interest. But yes, the immune response attacks the bacteria in the gut, and that your intestinal cells are the innocent bystanders. They still are injured. Clearly, there's ulceration and inflammation, but the primary target are the bacteria.
Now, I want to invite you, if you're listening, to call in if you'd like. Have you been diagnosed with an inflammatory bowel condition? What is that like? We welcome your questions or your stories at 888-472-3366. You can also send us email, radio@peoplespharmacy.com.
Now, it would seem counterintuitive to me that if the immune system is trying to deal with all those bugs, those bacteria, the fungi, the viruses that are setting up housekeeping in our digestive tracts, that suppressing the immune system might not necessarily be the best solution, because presumably the reason we're fighting them is because they shouldn't be there.
Well, the immune system is set up over the ages to attack pathogens. But in Crohn's disease and ulcerative colitis, there is evidence that recognition is altered, that your body assumes that these normal bacteria are pathogens and acts like it is fighting against pathogenic bacteria. So the current treatment of IBD still is primarily suppressing the immune response because it's an exaggerated, overzealous immune response. We normally live in peaceful coexistence with our bacteria. Those bacteria are altered somewhat in Crohn's and ulcerative colitis, called dysbiosis. But yet we haven't yet developed appropriate therapies in that area. I think that would be a much more physiologic approach.
Seems to me that as we go along learning, just now we're learning a tremendous amount about this balance of ecological system, as
Yes.
it were, in the gut. And what we've discovered is that it's actually different for, it's not the same from one person to another. It's different. And perhaps is there some difference, or do we know that yet, between the balance of bacteria and other organisms in the digestive tracts of people with inflammatory bowel disease versus people who don't have inflammatory bowel disease?
It's a very complex area, but to simplify, there's a balance of good and bad bacteria in all of us. In the normal situation, the beneficial bacteria outweigh the detrimental bacteria. But in Crohn's disease, ulcerative colitis, and many other conditions such as metabolic syndrome, fatty liver, even type 2 diabetes, and even atherosclerosis, there's an abnormality of that balance. And to simplify this mystical area, the bad bacteria overgrow and the good bacteria contract. And so there's a very characteristic dysbiosis, altered balance of the good and bad bacteria in Crohn's disease and ulcerative colitis. The bad bacteria proliferate, E. coli and other bacteria, where the good bacteria, the Clostridia and the bacteria that produce...
Oh, wait a second. Clostridia is a good bacteria?
Clostridia has many, many, many signatures.
Okay.
There's some very bad Clostridia, such as Clostridium difficile and those that can cause gas gangrene. But there are many more beneficial Clostridia, and some of these Clostridia produce protective metabolites that we probably want to get into, that when you eat high-fiber foods, these Clostridia produce short-chain fatty acids, or butyrate, that actually are quite protective for the GI tract. In the normal situation, our bacteria are predominantly protective. They stimulate normal immune responses. They stimulate food for the gut bacteria.
We're going to take a short break. When we come back, we're going to find out what are the good foods to help encourage our bacteria. We're going to learn more about prebiotics and probiotics and, how can we start creating a good ecological balance within our digestive tracts. And we're going to take your calls and questions, 888-472-3366. If our lines are full, send us an email, radio@peoplespharmacy.com.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible by Redix Industries, makers of utterly smooth creams and lotions that moisturize deeply to make dry skin feel soft and smooth. 800-345-7339. online at uttercream.com.
And by Squatty Potty Toilet Step Stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
If you would like to order a CD of this show, you can call 800-732-2334. Today's show is number 962, or find it online at peoplespharmacy.com.
Today, we're talking about the digestive tract. More than 1 million Americans have an inflammatory bowel condition such as Crohn's disease or ulcerative colitis.
Our guest in the studio is Dr. Balfour Sarter. He is the Midget Distinguished Professor of Medicine, Microbiology, and Immunology, and Director of the UNC Multidisciplinary Center for IBD Research and Treatment. He's co-director of the Center for Gastrointestinal Biology and Disease.
If you have a question about inflammatory bowel disease, this is your chance to ask one of the country's leading experts. You can give us a call at 888-472-3366, or you can send us an email, radio@peoplespharmacy.com. And we go to the phones, Joe. Alan in Charleston, West Virginia, welcome to the People's Pharmacy. Your question, please.
Hi, Joe, Terry, and Dr. Sarter. My question is this. I have an employee with Crohn's, and I'd like to be sensitive to their needs. How can I do that?
Well, I applaud you for your willingness to work with the patient. Most people with Crohn's disease are quite capable of working, but one thing you could do as an employer is to have a bathroom that's readily accessible. Many bathrooms are locked, they're down the hall, and to make it very convenient, because sometimes there's an urgency to get to the bathroom. And so accessibility can be an issue. That's something you could definitely help with. The other is periodically there may be flares, and accommodating working at home would certainly be helpful to many people. And those parents who have children with IBD frequently need to have a fairly flexible work schedule.
Alan, thank you very much for your question and for being so sensitive to this topic. Now, people may be wondering, what's it like to have an inflammatory bowel disease? And this is more than just a professional interest for you, Dr. Sarter. You have had to deal with this not just professionally, but personally. Can you tell us a little bit about your story?
Yes, and it's made me a far better physician, because I was a patient before I went to medical school. I was diagnosed as a college senior last semester I was age 21 last semester in college. I'd been accepted to medical school. I'd already made that decision to go that route, but this has profoundly influenced my career development. I'm clearly motivated because I was struck with the very poor assortment of medications back then. It was prednisone and surgery and azulfidine, basically. So I really wanted to get more at the cause of the issue. So as a patient, I've experienced ups and downs. The majority of patients do quite well most of the time. That's certainly the goal and the expectation, that we can get most patients into remission. But there are periods where there are flares that may lead to hospitalization. I've probably been hospitalized 3 or 4 times, and it is a period of great uncertainty. I was in the hospital for over a month as an intern, and I really had to think hard about career decisions.
We go to the phones. Shane in Greensboro, North Carolina. Your story, please.
Hey, Joe and Terry, and the good doctor. Glad to be on with you. I'm a registered nurse and work with lots of patients that have inflammatory bowel diseases of various sorts in the emergency setting. And I was wondering what the connections might be between emotional health and bowel health. Just anecdotally, seeing so many people who either have, very high levels of stress in their life for long periods of time, or have been victims of traumatic situations, or have those things in their history, also having these inflammatory bowel type diseases. So just interested in what might be the connection.
Thank you for your call, Shane.
Shane, great question, and it's one of the more common questions that patients have. What is the role of stress in either precipitating flares or actually causing these disorders? There's no evidence that stress actually causes the disorders, but clearly stress can affect bowel function. Normal people, when they're anxious, nervous, before taking a test in college, for example, can develop diarrhea and even some abdominal cramps. And so if you have a baseline of diarrhea, certainly stress can make that worse. But we think it goes further. I do think that stress does affect immune function and certainly affects the guts, the nerves. There's a brain-gut axis, communication both from the gut to the brain and the brain to the gut. So stress clearly can activate neuropeptides that can influence the inflammatory response. It's an area that's being rapidly investigated. We advise people certainly to try to avoid stress, but that's you can't go through life without stress. We don't believe that people should be given, the average patient with Crohn's and ulcerative colitis should be given antidepressants and anti-anxiety medications, but because stress is a normal part of life. But it certainly can influence function and certainly can lead to one's perception and adaptation to chronic disease. And that's true for many chronic diseases, not just Crohn's and ulcerative colitis.
Dr. Surter, we have an email. We don't have a name. It was texted in. I'm fructose. This person has fructose malabsorption.
Yes.
And is wondering if that can cause inflammatory disease or can it make it worse? And that'll bring us to the topic that we left dangling at the end of our last segment about what foods should we be considering as helpful.
Well, fructose malabsorption is a very specific and somewhat unusual condition, but and that is not usually associated with inflammation. If you can't absorb fructose, it leads to bacterial metabolism that leads to diarrhea, but not inflammation.
So it leads to some of the same symptoms. Yes,
the diarrhea and cramping. But if you do a colonoscopy, you would not see any inflammation. But on a broader picture, we have developed evidence in our own laboratory with experimental mice that developed colitis, genetically prone mice, that if you feed a high fructose or high sucrose diet, that the inflammation is actually worse.
So we're talking about sugar.
And we are talking about refined sugars that are almost ubiquitous in the Western diet. Huge loads of fructose corn syrup and sucrose added. So I advise my patients, again, I say, look, it's hard to go from mouse to man, but there's developing evidence that fructose, glucose affect your gut bacteria and actually increase the load of some of these detrimental bacteria that I was talking about earlier.
Well, of course, we have heard from Dr. Lustig, a renowned pediatric endocrinologist at UCSF in California, that this is a diet that's bad for diabetes, it's bad for metabolic control in general, it's bad for our weight, and now you're saying it's bad for our digestive tract.
And it's bad for your teeth as well.
So it's bad for us, but it's the diet we're mostly eating.
And one of the intriguing things, we talked earlier about 1.4 million people in the United States with Crohn's and ulcerative colitis, but these are Western diseases. They're very unusual in underdeveloped countries, but there's an explosion now of ulcerative colitis and Crohn's in Asia, South America, as those areas adapt our Western diet.
Suggesting that there are triggers.
There absolutely are triggers. So I view the pathogenesis, the cause of IBD, as 4 factors. There's genetic susceptibility. There are environmental triggers that start the process or reactivate disease with flares. Then there's the gut microbiota. We know more about bacteria driving the immune response that actually causes the damage. All of those have to interact in order to develop disease.
We were going to talk about food.
Absolutely. And so you've told us about foods we should avoid, anything that's loaded up with refined sugars. But what about foods that might be beneficial? What are the good foods that encourage the best bacterial balance?
Yes, that's the proactive side. I want to just emphasize that the statement I made about high sugar, et cetera, is still speculative. It hasn't been proven in trials. But,
right. It hasn't been proven in trials, so it's not absolutely certain that sugar is actually contributing to inflammatory bowel problems. But I think no one is going to argue that a high sugar diet is a wonderful thing.
Right. I'm a firm believer, which is why I don't add sugar to my morning tea. But back to your question about what is a good diet. I vigorously disagree with many of my colleagues that suggest a low-fiber diet in the setting of Crohn's and ulcerative colitis. I think there is one situation where that's appropriate, and that's when there's a tight stricture, a narrowing in Crohn's disease. But the majority of patients, I advocate a high-fiber diet. And the rationale is that fiber itself is like a sponge. It absorbs water and it decreases diarrhea. But I think even more importantly, it's the metabolic substrate. It's the food that the bacteria eat, the good bacteria eat, to produce some of these protective metabolites. Butyrate, short-chain fatty acids are used by bacteria to produce these short-chain fatty acids. And the source of that are non-absorbed carbohydrates that make it through the small intestine down to the colon.
So we're talking about foods that are high in fiber, but especially soluble fiber, no?
Yes, absolutely.
So, for example,
okra, eggplant.
Yes.
Oatmeal,
bran are all things that I advocate for patients. I have them avoid, if you have a stricture, avoid chunky foods like raw carrots, popcorn, peanuts, things like that. But soluble fiber goes through the gut quite well. So I believe that this is an area that people should use.
And prebiotics, we're talking now about basically, foods that our grandparents were familiar with. Sauerkraut, for example.
Yes. So prebiotics are food substances that are beneficial to the gut bacteria. And some people use them in concert with probiotics because it gives the good bacteria something to eat. Inulin and their commercial factors. They haven't yet been proven in clinical trials, but they really have been under-investigated.
Our number to join the conversation, 888-472-3366. We go to Lenore, North Carolina. Ed, welcome to the People's Pharmacy. Your story, please.
Hello, how are you all?
Nice to have you with us, Ed.
I grew up mostly overseas when I was younger. I did not come to the South until in my 20s. And then, of course, I love the food here. And I didn't get irritable bowel syndrome until I was a little older, and I got it really bad. Had a real rough time with it. And eventually I found out that just by changing my diet, I cut out all my fried food, and I don't eat hardly any processed foods at all anymore. I have just about completely done away with it. I live a pretty normal life now. If I eat something bad for about a week or so, like if I go to a reunion where they have a lot of barbecue and fried foods and stuff, it'll come back and get me a little bit, but not very bad. I can live a pretty normal life now, just by mostly by diet change. My one weakness is, though, that I do eat a lot of sweets still. I always have, and that doesn't seem to bother me.
All right, Ed, thanks so much for your testimonial.
Ed, you bring up many points. I think you're in your particular case are discussing irritable bowel syndrome, but I think there's a lot of overlap between food. The take-home message is that every patient is different. What works for one person may not work for the other, and that's the frustration as a physician. It's very difficult to give a IBD or an IBS diet because every patient reacts differently. And so it's a little bit of a trial and error. Fats in general are hard to absorb, so can cause problems in some people.
Dr. Sartor, we've got an email from LJ who says, my friend with ulcerative colitis was prescribed a drug that banished her symptoms, but a year later, this was back in 2000, she got acute myeloid leukemia, which did eventually kill her. One doctor thought that the ulcerative colitis drug she took might have caused the leukemia. We don't have a drug name here. Have you ever heard of such a reaction?
The immune response is basically in our bodies to fight against protection and also prevent malignancies. So in general, strong immunosuppressives can increase the risk of certain cancers. I don't think they cause the cancer, but I think they cut down on the body's reaction. There is no evidence that I'm aware of with leukemia with these medications, but lymphoma is a bigger issue. So some of the immunosuppressive agents have been linked, such as 6-mercaptopurine and azathioprine have been linked with a slight increased risk in lymphoma. It's a particular issue in young males where there's a particularly virulent form of lymphoma.
We've been talking about foods, the good foods that might protect our bacteria, the good bacteria versus the bad bacteria. There's a rather controversial new approach for something called C. diff infections. Now, this is a problem when people get certain antibiotics. In particular, clindamycin comes to mind, but there are other antibiotics that can trigger it as well. It's called a fecal transplant, and people go, ooh, poop. I don't think I want to try that. But if you're desperate enough, you might seriously consider it, especially when you have a C. diff infection. Does a fecal transplant help with inflammatory bowel disease to reestablish good bacteria?
2 weeks ago, I attended a symposium entirely dedicated to fecal transplant. And the fecal transplant works beautifully well in recurrent C. difficile infections, somewhere between 93 and 95% efficacy with a single fecal transplant. It's a much simpler situation, Joe, than in IBD. In C. diff, as you mentioned, antibiotics ablate the normal bacteria. And this pathogen, the C. difficile that produces a toxin, grows in that void. And so if you fill the void, you prevent the regrowth. In IBD, though, it's a much more complex, and if you do a single fecal transplant, it doesn't have staying power. So whether multiple will help, we don't know.
We need to take a short break. When we come back, we'll talk more with Dr. Sartor about irritable bowel syndrome. Nearly 1 person in 5 suffers from this problem at some point during their lifetime. Are you one of them? Share your story. Our number, 888-472-3366, or email us, radio@peoplespharmacy.com.
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website where you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redx Industries, makers of utterly smooth creams and lotions, helping dry, cracked skin feel utterly soft and smooth. 800-345-7339, online at uttercream.com.
And by Squatty Potty Toilet Step Stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
You can purchase a CD of this show. Just call 800-732-2334. It's show number 962, or visit the website. It's peoplespharmacy.com.
We're talking today about your digestive tract. Now we're mostly going to shift from inflammatory bowel disease to talking about irritable bowel syndrome, or IBS. We've already mentioned that it's less serious, but it's far more common. Estimates range from 25 to 45 million people in the United States who may be affected by irritable bowel syndrome. It can have an impact on quality of life.
Our guest in the studio is Dr. Balfour Sarter. He is the Midget Distinguished Professor of Medicine, Microbiology, and Immunology, and Director of the UNC Multidisciplinary Center for IBD Research and Treatment. He's co-director of the Center for Gastrointestinal Biology and Disease.
Dr. Sarter, before we leave inflammatory bowel conditions behind, we do have an email from Randall in Palmdale, California. He wants to know, what is the current research regarding parasitic worm therapy for Crohn's disease?
And you're going to have to explain this, because most of us have been, told for decades that parasites are bad, and we want to get rid of those worms at all costs. But we've been hearing a news story lately.
Well, the news story is that we, as cavemen, adapted quite well to worms, and worms actually can help develop the normal immune response. So the theory is that in the absence of worms, that there is a lack of appropriate protective immune response development. And there have been several studies by different groups that have demonstrated a possible protective role of worms, helminths, in Crohn's disease and ulcerative colitis. A recent large study, however, in Germany, doing a placebo-controlled trial, did not show any benefit. So, and it's also very important to know that all worms are not the same. The study in Iowa that was originally done was done with porcine roundworms, Trichuris suis. So many of the worms that are available on the line are hookworms, which can actually have detrimental effects with bleeding.
And I assume that the pork roundworms don't actually survive all that long in human intestines?
They don't. They were actually chosen because they do not survive. They don't replicate in the human gut.
Did I hear you correctly? The worms that are available online?
Yes, there are worms available online. You can actually get them from Asia.
So once again, as regards almost anything with respect to your health, be very, very cautious about anything you buy online, right?
Right. I'm going to have to digest that idea for a few minutes.
Well, we did say that we were going to move on to IBS, but we do have a question from Mike in Tampa about inflammatory bowel.
And a new drug. Mike, welcome to the People's Pharmacy.
Yes, hello, Joe, Terry, and Dr. Sarter. Thank you for taking my call. I've been diagnosed with ulcerative colitis for about 25 years now. I understand about a drug, forgive me about the pronunciation, vedolizumab, I believe it is.
Yes.
I was originally told that this drug was developed for Crohn's disease, but now I've been led to believe that it's actually working better for people with ulcerative colitis. I was wondering about the truth behind that.
Well, there is truth behind it. It's a new development. The FDA approved vedolizumab, or the trade name is Entyvio, about 3 months ago, and so it's now widely available. It is an IV injection, a so-called biologic therapy. It's a monoclonal antibody that blocks the entry of white blood cells into the inflamed gut. The beauty of this particular drug is that it's highly specific for the gut. It doesn't have effects in other parts of the body because there are gut-specific T cells, that a type of immune cells that are preferentially being blocked. So a previous drug that was used for Crohn's disease, natalizumab or Tisabri, worked very well, but had a very rare but frequently fatal complication of a brain infection, a so-called PML, progressive multifocal leukoencephalopathy. This drug, in theory, would not have that side effect, and there have been no evidence of the growth of that particular virus that causes that. So it is helpful in ulcerative colitis more so than Crohn's. It's a great option for people that have failed other biologic therapies.
So you would call this an important advance in the
Absolutely.
treatment of inflammatory bowel?
It's a new, it's a whole totally new approach to IBD treatment.
Well, Mike, thanks for that question. We have a letter from Ruth in Illinois. She says, I have irritable bowel syndrome. I have a lot of gas and I explode with diarrhea every time I eat. I go 8 to 10 times a day, all night, and she wants to know what in the world can she do about it. Her doctor prescribed Linzess, but that's just making the diarrhea worse.
Yeah.
So what kind of management can someone with this sort of really disruptive irritable bowel syndrome do?
Well, there are non-specific antidiarrheals that are over-the-counter as well as some prescription that certainly can be tried. But the reason there is so much gas is that there is bacterial production of gas as well. And so this is a situation where experimentation with different diets may be quite effective. And again, as I mentioned, it's a very individual type response. There are some antispasmodics that can cut down on the cramping associated with this.
Now, we talked a lot about bacteria in the belly, especially in the lower GI tract, for people who have inflammatory bowel.
Right.
Does bacterial imbalance play any role for people with IBS as well?
It does. Multiple groups, including a UNC group, Udi Ringel, have measured the balance of the good and bad bacteria in IBS as well as Crohn's disease and ulcerative colitis. And there are many of the similar features. There's an overgrowth of certain bacteria, decrease in others.
Someone we know pretty well developed IBS-like symptoms after a GI infection traveling abroad. Have you ever heard that before?
Absolutely. There's a subset of patients that have an infectious trigger. We call it post-infectious IBS. And it is probably accounts for about 15% of IBS onset. And there's clearly an environmental trigger in which they probably develop alterations in the motility of the intestine.
It's time to take a call from Sean in New York City. Sean, welcome to the People's Pharmacy.
Hello, Joe and Terry.
Hi, Sean.
Hi. I just happened to be traveling in my car, and I heard the discussion, and I'd like to share with you that I am an IBS sufferer. I've been an IBS sufferer for over, in my 60s, so I would probably say 47 years. And it hasn't been pleasant, and it has affected my life in probably many ways. And I still endure it, and I still try to find different avenues to take to try to alleviate some of the pain and the discomfort. And so that's what I've experienced. And usually, like early mornings, things of that nature is when mostly active. Afternoons aren't. But it stopped me from promotions and jobs and just taking certain employment that I wanted. So basically, it's not pleasant, and I'm always trying to find something to. I heard you just say something about antispasmodics. I feel that I've been going to doctors for many years, and God bless GIs. There was a lot of good docs out there, but a lot of them, they haven't progressed. When you go in there, they just tell you to eat more fiber, and they don't realize that for an IBS sufferer, there's two types of fiber, insoluble and soluble. And insoluble fiber is very bad for us. So the knowledge out there, it just doesn't seem to be getting any better. So the remedies I find as an antispasmodic, a heavy cup of peppermint tea, 2 or 3, very ridiculously strong, is what stops the spasms.
Sean, thanks so much for that. Dr. Sartor, peppermint as an antispasmodic. We have actually heard that some people take this in a medication, in an enteric-coated pill for calming the GI tract. Have you heard of that?
I don't have personal experience with that particular approach, but you have to listen to what works. And if people find that's effective, then I see no reason not to use it. Again, people have to experiment a little bit and see what works for them.
Is there any possibility that for someone like Sean that finding out how to encourage the good bacteria and discourage the bad bacteria, what we were sort of talking about for inflammatory bowel, might make a difference for irritable bowel as well?
Yes, in theory, probiotics have been used quite a bit for IBS, and there's pretty good evidence that some are effective. And again, dietary management is indirectly affecting the gut bacteria.
We go to Sarasota, Florida. Dr. William, welcome to the People's Pharmacy. What's this about lactose intolerance?
Hi, Joe and Terry. Thank you, Dr. Sartor, for taking the question. I was on a cruise in my 40s and developed bad GI, stomach pain, and constipation. It ended up lactose intolerant afterward and never been in my life. And as I get small exposures to, cheese, probiotic yogurt, I'm developing more of a tolerance. Is it possible to reverse lactose intolerance?
That's a fascinating question, and a couple of comments. One is that lactase levels, which is the enzyme that breaks down lactose in our small intestine, change over one's age. They're very high in the young, probably teleologically because of drinking milk exclusively in early ages, but they decrease with age. And sometimes a precipitating factor can be an infection that basically wipes out the small intestinal epithelium, and as it grows back, the lactase levels are diminished. There have been actual studies showing that certain probiotics can digest lactose, and that's probably the mechanism of why you're having some benefit with the probiotics that you're eating in yogurt and elsewise.
Dr. Sartor, as we're on the topic of things that people can do for themselves, we frequently hear from our readers and our listeners that coconut is very beneficial against diarrhea. What is your take on coconut?
And in particular, this all got started because of a fellow in Pittsfield, Massachusetts by the name of Donald Agar, who started eating Archway coconut macaroon cookies for his Crohn's that he had suffered with his entire life.
And Donald Agar, being an experimental mindset, actually discovered by accident that the Archway coconut macaroons were controlling his Crohn's-related diarrhea. If he ate 2 a day, he found that if he ate 3 a day, they made him constipated. And he found that if he stopped eating them, the diarrhea came right back.
Your experience?
Well, when I first heard this on your radio station, I said, I don't know about that. But I have seen over and over some of my patients coming in and swear by this very non-invasive way of treating their diarrhea. It doesn't work for everyone, but some people say it's quite effective. I actually had a bit of a story in which one of my patients who had such benefit that she went on a camping trip out west for 6 weeks, and she loaded up her van with Archway coconut macaroon cookies.
She didn't want to take any chances.
She didn't know what the source was. Could she find them out in the West? And she did beautifully well until she called me one day and actually had an obstruction, a blockage. And so, as you mentioned, too much can cause constipation. And in a patient with a tight stricture, the coconut residue can be problematic. So be a little cautious if you have a very tight stricture.
I would like to ask you about things to avoid. And there is a category of medications that that people in America love. I mean, tens of millions of people swallow these drugs every day. They're called NSAIDs, non-steroidal anti-inflammatory drugs. You can get them over the counter as ibuprofen or naproxen, the brand names, of course, being Advil, Motrin IB for ibuprofen, Aleve for naproxen. I have tennis partners who call ibuprofen vitamin I. They take it before, they take it after playing to avoid the inflammation and pain. These drugs can be tough on the digestive tract. I wonder about conditions like IBD or IBS.
Joe, thanks for bringing this up. I don't have any direct evidence in IBS, but this is a very important factor in IBD. I mentioned earlier trigger factors. This is I think, very well validated trigger factor. The ibuprofen class, the NSAID class, block protective prostaglandins that are protective in the gut, and not only can cause stomach ulcers, but can cause inflammation in the lower GI tract, the colon, and are clear trigger factors for worsening IBD. I tell all my patients with Crohn's and ulcerative colitis to avoid this class of medications. Tylenol, parenthetically, does not have such an effect on the GI tract.
Enteric-coated aspirin, people think, oh, no problem, it'll bypass the stomach, but you can damage the small intestine.
You sure can, and in fact, you get a high concentration as that pill dissolves, and we see ulcerations in the small intestine. We do something called a capsule endoscopy, and we can see these lesions quite commonly.
Dr. Sartor, we like to leave our listeners with a place where they can go to get more information. Can you tell us about the Crohn's and Colitis Foundation of America, please?
Yes. The CCFA is a nationwide patient-based organization, and it has one of the very important things it does, other than sponsor research, is to have a very well-validated website. There, on the online, there's a lot of misinformation, but the ccfa.org is a wonderful source of reliable information.
Fabulous, and we will put a link to that from our website. And that is all the time we have. We want to thank you for listening to The People's Pharmacy, and we want to thank our guest, Dr. Balfour Sartor. He is the Midget Distinguished Professor of Medicine, Microbiology, and Immunology. He's also the director of the UNC Multidisciplinary Center for IBD Research and Treatment, and the co-director of the Center for Gastrointestinal Biology and Disease at the University of North Carolina at Chapel Hill. Until recently, he was the chief medical advisor of the Crohn's and Colitis Foundation of America.
Lynn Siegel produced today's show. Sophie Copeland provided technical assistance. Al Wodarski is the engineer, and Dave Graydon edits our interviews.
Today, we'd like to welcome our listeners at WHQR in Wilmington, North Carolina.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
To order a CD of today's show, you can call 800-732-2334. Today's show, number 962. That number again, 800-732-2334. Online at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening, and please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.